This series of webinars has the main goal to share with you information around the region about implementation of infection prevention and control practices, discuss some practices, and as well share experience from countries and experts in the region. If you are not enrolled yet, we also have a course that is a monthly course from different topics that we cover in deep at the discussion of specific practices of infection prevention and control. So our next course will be in April, and I invite you to be to look for the information. So we will share with you later about this next course. So I would like to thank you all of you and welcome you for your participation and your interest in this series of webinars. We are happy to be able to do these webinars with experts from our region and have your support by engaging during these opportunities. So it will be a 1 hour session. We will have around 45 minutes of presentation, and then we will open for questions. The questions need to be placed on the questions and answers tab that you have in your screen. For some of you will be in the below part and or the top part. So please put your question there and we will answer it by the end of the presentation. So the webinar today will be not in Spanish, sorry about that. Will be in English and we have translation for Spanish and Portuguese. So if you go in your tab, you will see a globe, and that globe will give you a globe icon. That globe will give you the opportunity to change the language. So we have translation available. So if you are not able to find it, please let us know, then we can help you on it. Before we start, I also would like to thank people who are making possible that we have these conversations and these webinars. We have our translators who support us during these webinars and also during the questions and answers, and make possible that we are all understanding each other. And then we have also colleagues from the health service pillar and also the IMST who are behind the scene making possible that we have it. So I would like to thank personally Jimena Terrazas, Maria Claudia Guzman, Soledad Urtia, and Howard Guetta, who help us before, during, and after the webinars. We are having some challenge with our panelists today. So I will ask you for connection. So I will ask you few minutes to her to be able to connect properly. And then we will start. Thank you. So good afternoon, colleagues. For those who enter in the room after my brief introduction, I just would like to let you know that we are face some challenge for the connection of our panelists today. So we ask you a few more minutes to be able to overcome the challenge. Thank you very much. So colleagues, thank you for your patience. So we are still trying to solve the problem. Apologies for that. So we will start as soon as possible. Thank you. Colleagues, once again, we apologize for this inconvenience. So we will start as soon as possible. Thank you. So good afternoon again, colleagues. So I really thank you, our patient, in this during this process. We are almost solving the problem. So before we start, I'd like to go through some of the general informations again. That will be an hour session. So we are expecting to have 45 minutes presentation and questions and answers by the end. So I will ask you again to put your questions on the questions and answer tab, and we will answer it by the end. The webinar today will be in English, but there is translation available into English and Spanish, and Portuguese. So you see an icon that is a globe. So if you click on the icon, we'll be able to open a Spanish or Portuguese translation and hear in the language that is more comfortable for you. Again, I would like to thank the translators, the health service pillar team from PAHO, especially Jimena Terraz, Maria Claudia Guzman, and Soledad Urtia, and Raul Argueta for their support during this preparation. So we will have today the experience of Jamaica. I believe Dr. Nicholson is almost connected. So she is my consultant in medical microbiology in the University Hospital of the West Indies, and senior lecturer for the University of the West Indies. She's former head of the Department of Microbiology chair, and chair of the Infection Prevention and Control Committee. Her lines of research are antimicrobial resistance and infection control. And she will share with us today the information or how the University Hospital of the West Indies prepare themselves and face the COVID waves here in Jamaica. So For those who are from the Caribbean, you probably know her because she is one of the regional experts in the area of AMR and also infection prevention and control. So if you're from outside, it will be a good opportunity to you to know her work in those two areas, and specifically in IPC during this COVID-19 response. Let me see if Dr. Nicholson, no, she's, so we still not seeing her here. So please allow us to few more minutes to be able to have her on the call. I'm so sorry. Yeah. So good afternoon again, colleagues. I hope you, so I apologize for the inconvenience that we have with the presentation, the connection, but we are ready to start now. So today we have with us Dr. Alison Nicholson. So she's a consultant in medical microbiology at the University Hospital of the West Indies, and a senior lecturer at the University of the West Indies. She's a former head of the Department of Microbiology, and she's chair of the Infection Prevention and Control Committee. And her lines of research are antimicrobial resistance and infection prevention and control. So Dr. Nicholson, we thank you for your participation. And we know that all this challenge to connect was stressful. So thank you for persist and connect with us today. So the floor is yours. Thank you.
Thank you very much, Dr. Valesco, and good afternoon, everyone. I am trying to open my presentation and then we will start. My apologies again for the late start. Oh no. Oh, okay. Okay. Okay, Dr. Valesca, can you allow me to share my screen?
I believe you can share, right?
Are you seeing it now?
Yes, we are seeing
okay.
now.
Okay, great.
Dr. Alison, we are not hearing you.
Right, I haven't started speaking yet. I'm just arranging my
so
papers. I'll be with you in a minute. Okay, so I want to thank the organizers for inviting me to share our experience with COVID at the University Hospital of the West Indies, Kingston, Jamaica. It was Charles Dickens who said it was the best of times and it was the worst of times. And I think I share that sentiment just thinking about what has happened thus far. I'm sure most of you can identify with what I'm saying. We saw the suffering of persons affected by COVID as they struggled to breathe and as they lost their fight. And we mourned their loss and we mourned with their loved ones. And for some of us, we still mourn. But we also saw the overarching generosity and gratitude of a nation wanting to express thanks to us, the healthcare workers. And they did this in so many different ways. For example, I'll share a few. They erected a banner across the entrance to the hospital expressing gratitude to the healthcare workers. Members of the police force came to serenade the healthcare workers, of course, accompanied by all their instruments. Restaurants sent food, they sent meals to us, persons on duty at different hours of the day and night. And of course, last but not least, the private sector of Jamaica came and offered and actually did go through with it, buying any equipment and reagents that we needed. I could go on, but we have other things to do. So indeed, it has been the best of times and the worst of times. And so this afternoon, I invite you to join me in looking back over this period thus far. In December 2019, Jamaica woke up to the news of a brand new virus causing concern in Wuhan, China. And by early 2020, this virus had eluded the prevailing diagnostic, test, was identified as a member of the coronavirus family, and specifically SARS-CoV-2. In a few short months, Jamaica joined the rest of the world in waiting to see when, not if, this virus would come to its shores. So I want to take a look back in order to look forward. I want to look back at where we're coming from and to just set the stage to show where we're going to and how what happened back then played a role in what's happening now. Dr. Valeska, there are messages in the chat. I'm going to just take a look. I'm not sure if they're mine. Okay, no, they're not. Okay, I'm sorry. I'll continue. So way back in 1948, Professor S.D. King, one of our stalwart professors of microbiology, started influenza testing at the University Hospital. The Department of Microbiology, which is stationed at the University Hospital, although it's a department of University of the West Indies. So way back in 1948, her interest steered her in that direction to start influenza testing. So she was always scouting out, detecting when it first came, and then collecting isolates, and in conjunction with WHO, determining their strains and so on. In 1952, NIC's National Influenza Center. So this predated the establishment of National Influenza Centers. And in 1952, National Influenza Centers were established by WHO. In Jamaica, Professor Grant, Louis Grant, again, one of the founding fathers of microbiology in our neck of the woods, he established the first National Influenza Center in 1952. So we were right there at the very beginning when the National Influenza Centers were being established. And the microbiology department continues to be where the National Influenza Center for Jamaica is housed. So enter COVID testing. When it did, the National Influenza Center was the obvious place to launch testing for the virus. To continue looking back a bit more, in 2015, there was the Ebola scare. And so we started what we thought we were establishing an airborne infection isolation room. We thought that would provide adequate protection as well for a pathogen as dangerous as Ebola. And so we started the construction, but you know, Ebola blew over before we were finished and it was just left languishing there. But the framework was there. We just needed to fine tune it and adjust it a little bit more. In 2017, there was major refurbishing of the ICU A. And we have two ICUs at the University Hospital, ICU A, ICU B. ICU A is a surgical ICU and ICU B medical ICU.
Dr. Nicholson, apologies. Yes? May we speak a little bit slow?
Okay, all right.
For the translators. Thank you.
Can you feel free to tap me on the shoulder again if I've forgotten and start going fast again?
Okay, sure. And we are not seeing the presentation mode.
Sorry, you're not seeing it move? Oh, I'm pressing and it's going ahead on my screen.
No, we're not seeing on presentation mode. Is on purpose?
No, it's not.
Okay.
Is that better?
Yes, thank you.
I was using the slides at the side, but I can manage. I'm okay.
Okay, thank you.
All right, so I think I went back one. Okay, so this is where we were for refurbishing of ICU A. In 2018, the University Hospital secured a grant from the Universal Service Fund to establish an infection prevention and control unit. We've always had an infection prevention control committee, which means that all the major players would come together from time to time, again in the Department of Microbiology. It certainly wasn't a once-a-month regularity, once every 3 months or even longer. But in 2018, the current Chief of Staff, Dr. Carl Bruce, decided that it was important to actually have a focus. So he established the infection control unit. We actually have a room now, quite a comfortable room that can seat the infection prevention control staff. We were given enough funds to furnish it, including getting a smart board, etc. So we're well on our way. We got a number of different items that we long wanted. We were able to get them during this time. So we have a somewhat cohesive team, still not there, but at least there's a foundation set. And in 2019, occupational and safety, health, occupational and health, so that's OSHA, occupational safety and health, was fully established in our hospital. Prior to that, most of the complaints that OSHA has to deal with now, infection control somehow got drawn into them. So if nobody else is glad, infection control is extremely happy that we had OSHA on board when we had this bigger challenge to face. Now, a little bit more of the background. We have always placed focus on hand hygiene, but we have been partnering with the international bodies as they have placed emphasis on hand hygiene. So we have launched hand hygiene campaigns. We have kept abreast with what is happening internationally with the different days being observed. And so we have mobilized our staff to be more aware of hand hygiene. They know about the 5 hand hygiene moments. We've been doing surveillance. I can't tell you much success there, but we continue to plug away at it. And in a sense, we believe that COVID is going to push us forward in terms of what we've tried so hard to do on our own. Personal protective equipment, we've also talked about that, and we have electronic notice boards across the hospital where we show little skits that we have done, video presentations, just to bring out how these are put on, taken off, etc. So we did an infection control DVD, and we have used that in training. So this was long before COVID. We would have persons coming to the department where we would house them, whether it be 30 at a time, or we'd go down to the main medical lecture theater when we have a bigger group, and we would go through a training program on infection control. Now, it wasn't complete by any chance, but it was meant to give them a bolus of the most important aspects of infection control. After that, this was followed by a quiz, and we told them that 85% was the acceptable mark. Below that, we would consider that they have not passed. They were all very excited about it, and the quiz came right after the session. So their, recall was pretty good then. Not sure what happens sometime after. So all of this was drawing attention to the importance of infection control. And I think that we made a mark on the hospital, and they took notice. I can't say that their compliance went hand in hand with that, but we did try what we could do. And this is basically just saying some of what I just said before. So this is the preamble, introduction. Now enter COVID and finding this work in progress. But I'm going to call this particular period, for ease of presentation, I gave you background, historical background. Now for ease of presentation here, I have divided the presentation into 3 parts. BC, which is before COVID. What I just gave you was like before BC, it passed. Now I'm saying just before COVID, this is what we did. During COVID, that's DC, this is what we did. And there I include a 3rd section, AC, after COVID, what we will do or what we would do. We'll see as we go on. All right, so the medical chief of staff, I've mentioned him before because he has been very instrumental in our preparation and in our response to this challenge. But the medical chief of staff stepped up to the plate and took charge, basically. He formed a core team, persons with strategic roles in different areas, such as A&E, ICU, IPC, that's infection control, and nursing and internal medicine, and a few others. The CEO was also a part of this. So out of this group, he had a governance team emerging. Now, in addition to that, he developed a working team, a working group, where you had representatives from all areas of the hospital. And when I say all, I really mean all. So if you could move, there was a committee to include you. And then we would take probably somebody who would lead that committee. So we had the hospital boardroom, which hereafter known as the war room, where we huddled to plan, to hatch our plans, our pandemic plans. These are the committees. I think I captured all of them, but I may have missed 1 or 2, but these are the main ones. So whoever we thought had an interest in education and training, management of patients, and I won't bother to go through all of them, but if you're not seeing any any mention of a particular committee that you have an interest in, I'm going to ask you to tell me at the end of this period. So just take a quick glance and then tell me if I missed out something. All right, again, as I said, our chief of staff led this thrust, and from the committees that we had, we pulled out some of the more major players, and we formed what we came to call our task force. And that task force has been meeting for the past 3 years. In the early stages, this is in preparation for COVID now, we met at regular intervals, the notice would go out and we would come together, we would huddle, we would look at what if, and we made our plans and our alternative plans. We looked at all the complications, potential challenges. We turned it upside down, inside out, but of course, nothing prepares you for the real challenge of COVID as much as COVID itself. So it was very time consuming, but it was worth it. We had all of our goals, our challenges, our pros, our cons, and we came together. Everybody was excited to be a part of this, and everybody was scared, and everybody was interested to make sure that we succeeded. And I just want to say, never underestimate the ripple effect on those around you of a team of persons who are functioning like a well-oiled machinery throughout the hospital. And you're signaling danger ahead, all hands on deck, man your positions and be ready for action. It didn't have the effect of scaring persons as much as it galvanized them into action, and it made them want to know what they could do and how they could do it. Now, many factors have been identified that needed to be addressed in order to significantly deal with the problem of infections in healthcare setting. And this chart, I'm sure everybody is aware of this. So you have administrative controls, engineering controls, and these work together to eliminate pathogens as much as is possible. We also focused on personal protective equipment. And we know that this is just a small part of infection prevention control, but it is very effective, and it's particularly effective when you're looking at the individual as opposed to the institution. So while we recognize the larger needs, we also paid attention to the PPE, which focuses on the individual and gives them some amount of autonomy, stroke power in the situation that they're facing. So we basically decided, how do we prioritize the needs that are there? So we know we have the infrastructural needs, etc. How do we look at all of the needs that are mentioned or that would be included in the preceding slide? I'm going to slow down a bit, Dr. Valeska, because I think I've started speeding again. Okay, so we wanted to pay attention to infrastructural needs. How do we deal with these? We need to reconfigure the wards. So in some cases, the way the wards were arranged would not allow us to separate COVID from non-COVID. We have the open ward system at the University Hospital. Sorry about this, I'm sorry. We have the open ward system at the University Hospital, and whereas we do have some private rooms, those are woefully inadequate. So the main focus of our, the main structure are the open wards, rows of beds, curtains just separating the beds. We do have a few private rooms on the side. And of course, we do have a private wing to our hospital, the Tony Thwaites wing. However, for the period of COVID, the Tony Thwaites wing would not accept COVID positive patients. So patients had to be screened before being admitted to Tony Thwaites. And so basically they were stuck with us. There was a period when we were the only admitting place. Well, sorry, us and the hospitals, the government hospitals, private hospitals were not admitting patients who were positive at all. From they heard that you were positive, patients were then referred to the university hospital or one of the other public institutions. So looking at the structure that we had, how could we optimize what we had? So we had to look at the wards and reconfigure them. So initially, where we thought we had perhaps one isolation area, we now recognize that we needed more, and I'll get to that in a little while. We would take a ward and we would say, how could we turn this into a COVID ward? What would we need to do? And then we would set about making the changes. It was amazing to see our workmen the department that has to deal with that, how they were able to change how the university hospital functioned. So we also looked at the lab, and we again tried to figure out, so the National Influenza Center is housed in the virology section of the Department of Microbiology. How can we have COVID testing alongside the rest of our viral testing without getting in each other's way? And we had to step back. I found myself at that point, for most of the time of COVID, I was head of department. And so I found myself putting on many caps. I found myself thinking in ways that I never thought I could think. And so together with our support persons, we were not short of help, and we were not short of interested persons. We would come together, knock heads, and a building that looked almost impossible, we would then find ourselves dividing it up, changing entrances, changing exits. Nothing was impossible. If somebody came up with a suggestion, we looked at it before discarding it or before accepting it. So we had to look at how we could change the wards and how we could change the lab, and we did. So now we have a virology lab that is set aside for the usual viral testing. We had started doing the BSL-3 lab. I mentioned that to you, that is on one side. So we separated that and we kept that as our COVID lab. Although you don't need a BSL-3 lab for your ordinary COVID testing, it served us well in that it reassured the staff, because trust me, they were scared as well. So having the BSL-3 lab and recognizing all that you had to go through and what you needed to do to prevent reinfection, it helped to get them to participate in what we were doing in a more willing way. So we now have our virology lab separate, and then we have our COVID lab. As to what we'll do after COVID, and I'm assuming there will be an after COVID, we're not sure yet, but at least we have choices. Then we have the major clinical departments were advised to have two teams, a COVID team and a non-COVID team. And then they could decide, depending on the burden of duty, how long would a COVID team last for, and how long would when would they exchange, because they would be on COVID duty and then they would get a break, they would get a few days off, and then they would come onto non-COVID duty, and then they would exchange. When we were considering things like these, it made the staff know that we were with them and that we were concerned about them, and that we wanted to make whatever changes we could that would be best for them. We also recognized that we needed more staff, and that was a challenge. How can we attend to staffing needs in all categories? Where is the money going to come from all of a sudden that we never had before? But I must say that our government, through the Ministry of Health, stepped up to the plate, and I could never fault them. They really were with us the whole way, over and above what we could have expected, and they provided whatever we needed. So we got more staff. In addition to that, persons who were retired would come back, and then they would stay in the offices to free up persons who were younger, a little younger, to be able to function out there on the ward. In terms of equipment, again, the government really helped, and they went way above and beyond what we expected. And the private sector, as I mentioned earlier, stepped in. The private sector just wanted to find out, what do you need? Just tell us what you need, tell us the suppliers, and we will do the rest. And they really helped us. As a matter of, well, yes, let me just leave it at that. They really helped us. Now, the isolation facilities, as I mentioned before, we had two languishing. So we had the BSL-3 lab, which we were able to do. And then we had the isolation, the airborne infection isolation room that we were able to actually get going on. And that was a challenge. It was a challenge. Dr. Valeska came and she saw it while it was while we were doing the work. And we needed to say, so what are we going to do here, and so on. But it was completed, and we were able to put in electronic surveillance, so somebody could view the room from across the corridor to reduce how many times you had to go in to deal with the patient in real life. Supplies, what about our personal protective equipment? This was important because you know that at that point, our wealthier counterparts in other countries were not, at points they clamped down on supplies leaving those countries. And so it wasn't always easy to source supplies. I'm sorry, there's an aircraft overhead. It will soon be gone. Don't know if you can hear it. Okay, so at points, we were not able to source personal protective equipment, but when we recognized, I think it took us a while to kind of catch up to the challenges that we were going to be faced with. And so we were thinking preemptively. In no time, we were able to strike before, and we were able to plan ahead much more effectively as the pandemic progressed. So we diversified our suppliers. We were well aware of the fact that not all masks were proper masks. And so we had to make sure that we scouted out and not compromise on the quality in return for quantity. We needed both. That's the problem. We needed both quantity and quality. I think we straddled the lines appropriately, and we were able to use perhaps the more inferior types in low risk settings, while we reserved the better types for the high risk settings. So those were some of the challenges that we faced in that area. Now, in terms of the lab, this slide is a little bit out of place, so I won't bother with it at this time. In terms of the lab, Dr. Valeska and Dr. Shaw, Dr. Valeska from WHO, from PAHO WHO, and Dr. Shaw from MOHW, Ministry of Health and Wellness, came to do a walkthrough of our laboratory to determine the level of readiness for testing. And later on, Dr. Valeska came back with Juliana, again from WHO, and they facilitated training of the laboratory staff in PCR testing of SARS-CoV-2. And I must mention here that this was with Professor Monica Smykel as our local lead, and Professor Smykel functioned as head of the National Influenza Center for many years. She has done yeoman service, which I never hold back from commending her when given an opportunity. Our testing also included included the interpretation, not just the execution of the test, but now how do we interpret the results? And I remember there was quite a bit of backing and forthing where that was concerned, but I think we eventually got it down. And when we look back, I think our results are credible. So in terms of CDC telling all countries what would be expected of them, we should prepare for containment. This would include active surveillance, early detection, isolation, and case management, contact tracing and prevention of onward spread of SARS-CoV-2 infection. And of course, we were reminded that all of this data should be shared with the WHO. So on the 28th of January, we had a case in A&E, and we were all alerted. I think I was called near to midnight, that there was a patient in A&E who had a travel history and who had symptoms, and the diagnosis was suspected COVID. This served to concentrate our minds wonderfully, and we consider it now in retrospect a blessing in disguise. The truth is, it showed us very clearly that the lab was not ready and the staff members were not ready. I was amazed at the amount of fear and uncertainty that we encountered. We realized that the logistics needed more work. The flow of traffic from the A&E to the lab needed to be sorted out. What seemed like a simple thing, the patient would be in A&E near to the airborne infection isolation room. The samples would be taken. Sorry, 1 second. The samples would be taken, and then they would be put in igloos with ice and carried to the lab. It seemed simple at the time we were devising the strategy, but all of a sudden when it needed to be implemented, nobody wanted to touch the igloos, and nobody wanted to walk with the sample in the igloo or outside of the igloo in a biohazard bag or anything like that to the lab. So we had to go back to basics. We had to go back to training the porters, reducing the level of fear, etc., etc. Fortunately for us, this was a false alarm. The PCR was negative, but that propelled us to go full speed ahead to complete our preparations and to realize how we would have been caught completely flat-footed had that sample been positive. So we stepped back again to review our lab facility. talked about reconfiguring the entrance to the virology lab so that we would have separation, so that the virology staff would not feel afraid of having anything to do with COVID per se. Of course, they're far much more relaxed now, 3 years down the road. But initially we came across some really strong barriers that we had to try and figure out ways to get around. And then the persons who are doing COVID testing, surprisingly enough, the young ladies who signed up for COVID testing, most of them are still with us and they are quite fine. And we're really grateful for their commitment and the kind of courage that they showed in an atmosphere of fear and uncertainty. The BSL-3 lab that we needed to be completed was completed largely, probably have 1 or 2 little kinks that need to be ironed out, but it has been completed. And although we don't officially really need that, it has served as a safe space for the lab to function, feeling as if they're okay and separated from another section and other sections of the hospital. We were able to get some of the additional staff for COVID, specifically for COVID that we talked about. And we continue to have our meetings that we use to educate the staff on. So on March the 10th, we had our first real case of SARS-CoV-2. By this time, the airborne infection isolation room was finished, largely 99%, I would say. So we were able to use it. And on March 11th, WHO characterized the COVID-2 as a pandemic. So in a nail-biting finish between the query case of COVID, the falsely identified case of COVID, and UHII preparations, I think that we could say that the UHII won by a whisker because our first real patient arrived on the 10th of March, just after preparations were completed and just before the pandemic was called. Of course, later on in March, a cluster of about 20 patients in association with the first case identified fell on our doorsteps and exposed to us just the beginning of what we were going into. So this is just a quick look at our negative pressure room with keyboard control door and contact and airborne precautions. It's 1 bed, but potentially 2 could hold. This picture, this is just a picture that we have here, sorry, of somebody from the room across. We just inserted the picture. So the person is in the room across and could electronically monitor what was happening in the room, in the airborne isolation room. So the next phase, the next phase is now during COVID. So we talked about the lead up to COVID in terms of our preparation, identifying our lacks, seeing what we needed in terms of staff, equipment, and reagents. And then now we're going to be looking at during COVID, how did we change gears and what happened? One of the things that we committed to, and largely we were able to do it, was continuing education. The newness of the infection and the lack of certainty about some things created a great deal of fear and panic throughout our staff. We saw that as persons became more aware of what this was, that coronavirus wasn't something new in terms of it, the common cold, but there are different strains, et cetera, et cetera. And as we talked about the developments, we won people's confidence and we got them to relax somewhat. So we found that our doctors, once they understood what was happening, we had them on board and they were far more cooperative. You'd be having doctors who would volunteer to work with COVID patients and it wasn't a problem. The nurses were a little harder to get on board, but eventually they came. There are still we still have challenges there, but we found that keeping people educated and keeping them up to date with the developments in the field was important. And it actually had a positive impact. So it was a deliberate decision to continue these sessions. And as you can see them spread out here in April, May, June, July, and this is December. And then in 21, we started them, we did them again. In 22, I think we may have had one session in 22, but it's definitely on our list to continue. And even during this hiatus, we will still be continuing to do training and to keep persons aware of the strides that are made just to reduce their stress level and to increase their comfort level. So during this COVID period, even though we had sensitized persons to PPE, now it's real. All of a sudden, what they had learned before, they're not remembering because now it's real. I'm standing in front or I'm about to go into a room. What do I do? What do I put on first, etc. And so we had to keep going over this. We had to provide training for persons. We wanted all members of staff to know that to be trained in knowing which PPE to select. And so we had a document that we adjusted to our situation, showing the risk assessment. And therefore, if you're going in to select your PPE, what questions do you ask, and how you answer those questions will determine what you need for your personal protective equipment. We also continued training in donning and doffing. We highlighted the fact that it is in the donning and the doffing sometimes that you can, especially the doffing, that you can actually auto-inoculate. And therefore, it is important to follow the steps. We know that our doctors prior to this would just burst the gown from the back or the front or wherever, just pull and yank and throw and don't really pay attention. So this required us to change the culture to say, no, there is a way that you need to remove your personal protective equipment that will perhaps cause the lowest possibility of your being affected. It's still, we know it doesn't remove it totally, but at least you would know that you've done your best. Of course, we wanted persons to practice what we had taught them about hand hygiene. And we wanted to remind them, especially in this case, how much hand hygiene is associated with transmitting the infection. So if you increase your hand hygiene, you will reduce the likelihood of getting it. We also, and I'll show you the charts that we used in a little while. That's a little further down. We also looked at optimizing personal protective equipment. How can we do that? We are not a rich country. Supplies are low, but we don't want to endanger our patients and our staff. So how do we optimize the use of our PPE? And so we looked at what we needed to do. We contacted our colleagues who were abroad, all over, wherever they were. We would be in touch with them. They would be in touch with us. We would hear what is going on. We particularly like to hear what was happening in the Ivy League universities, knowing that we may not be able to match them, but at least we know what they're doing and we see how close we can get to at least understanding the principles and implementing what we could manage to implement. So in terms of the surgical mask, if the surgical mask is damp or if it's damaged or visibly soiled, then you know that you have to discard that. However, you may also be using a face shield because the face shield can actually prolong the life of the mask, and you can probably be using 2 per day, sorry. The face shield and goggles, how do you clean those afterwards? I know, for example, in Canada, and I'm sure other first world countries, the goggles were disposable items. And I look at goggles and I say, no, why would these be disposable? Some of them are flimsy, yes, but some are really of very sturdy material. And for all practical considerations, should never have been disposable, but you know how it is. And there are many reasons, you know, you have all kinds of theories. But the fact is, when the crunch, when the crunch came, even in Canada where goggles were disposable, they were now reusing them. They had to clean them, find a way to clean them and use them again. And so we were learning. So we were finding our own way, but we know what are you doing and how can we mix and match the methods to get something that's suitable for us. So we were not disposing of the goggles because we know we would not have a supply to support that. So we found a way to clean the goggles, and we had to devise our strategy of how are you now going to take off? What do we need to put in the doffing room so that you can have receptacle for your goggles with a cleaning agent nearby? And how will you wheel that into your procedure? So into your the procedure of changing. so that when you're finished, you leave the goggles there, and that is taken away. The set might be taken away, cleaning is continued, and then you will pick up your new goggles, so your clean goggles somewhere else. And in terms of your N95, no, that was another query, because N95 masks are not cheap. And if we were to dispose of them, we would probably run into problems. So again, we asked around, we thought about ourselves and we tried to figure out what can we do. And so what we did was to get paper bags, and we would label them day 1, 2, 3, 4, 5. And so you would put the mask, the N95 in your, take out your first mask. And after you've finished using it for that day, as long as it's not soiled or damp or damaged in any way, you would put that back in the bag, in the bag marked day 1. Then for the next day, you would take out the one from the bag marked day 2, etc. And after day 5, you would go back now to the used N95 mask, and you would reuse that on day 6, and so on. So you would get extended use from that. And I'm sure there are persons listening who also practice that, but just in case, I've gone into a little bit of detail as to how we did it. And it worked. Persons were with their paper bags or any other storage thing, but we felt paper bags were probably the best. And we were keeping our N95 masks going. So basically, this is what your member of staff would look like. And as I said before, we kept ongoing training. We didn't ease up with the training because we know that people will forget, and we know that practice should make perfect, but we were going right alongside them to make sure that if they had any questions that came up, because sometimes it is as you were trying to execute these measures that you realize all of a sudden, should I do this before that? Or did I miss a step? So we were there on spot to be able to guide them through and to assure them. So some of the questions that I mentioned or alluded to earlier included, all right, how is this transmitted? Where does it enter the body? How can I block transmission? How will this PPE prevent the virus getting to me? It's not a magical, mystical thing. There is a science behind saying if you do this, your chances of getting the virus are greater. And if you do this, your chances of getting the virus would be less. So we wanted to demystify that and to help people to keep this set of questions in their minds so that they can know how to choose their PPE when faced with different situations. And going on from that, we then modified or customized this risk assessment form for our situation. So these are on the left side here, you have the procedures or the situations that you want to find out about what kind of PPE you would use. And then this tells you the type of gown you would wear, the mask, the shield, the goggles, etc. And we have another one on this side, which is just also going through the situations. I know you can't digest this now. The presentation will be available, I think. And most of you probably are aware of this, but it goes into be modified it for our situation. So even if there's another one out there, this one is modified for our situation at Cornwall Regional Hospital, at University Hospital. And we were able to go through these with persons to kind of give them some autonomy. It's not just a matter of saying, oh, infection control says this, but you can actually work out what it is you need if you understand why you need it and how you are going to break the chain of transmission. Just want to look at the gowns for a little bit. We haven't mentioned them much. When we started out, we were using these gowns, and we were assured by our colleagues in other countries that this was a gown that they were using as well. And they use them on the ward, and they use them where the COVID patients were, and they were fine. Of course, they had all of this stuff, the gloves and so on. However, one cohort of our doctors decided that they were not buying it. So they got either water pistols or some other things, and they pushed, came at the gowns with force and saw that water went through. So this was their case. They were not safe, and they were not about to use these gowns. So it was a protest. However, we were able to assure them that there were different levels of gowns, and therefore you get different levels of protection. So this has been proven to protect at a certain level, and we're certainly not saying that you can use this for patients who are critical or patients, depending on respiratory tract and so on, infection. but in certain low risk areas, in order to spread the supply of gowns across the whole area, you can use these in certain low risk areas where you're not going to be coming into direct contact with the patient. We eventually changed them because we ourselves thought they were a bit flimsy. And I also heard later that the colleagues that we had heard from had also changed theirs. But we changed ours independently of theirs because our staff wasn't comfortable. And although we were assured that as long as you use it in certain areas, it's okay, we made a change, which also signaled to the staff that we are listening to them and we are concerned about their cares. So this is just looking at the different levels of gowns that there are. And for many persons, a gown is a gown is a gown. But of course, we had to go through the different levels and the different types of risks that you can take. So we even got the gowns and got water to pour on some to show that it was really impermeable. That was like the level 4 or 5 gowns that you use in surgery. So for some persons, this was a revelation because they thought, you know, all gowns were equal almost. So as the numbers increased, we needed more wards for COVID care. So as I mentioned before, and I said I would come to it later, so I'm here now, just talking about how we were able to look at the wards and reconfigure them. So the first ward we identified was our medical ward, Ward 7. And we decided that we would make an entrance. So we were now along the corridor, and it's hard to tell you without pictures that we were, which I don't have the construction pictures. If we had thought about it then, we would have taken pictures of everything we were doing at the time we were doing for posterity, but we were just feverishly trying to finish the place and to make sure that we were able to handle the challenges coming in. So, sorry. We basically looked at the ward and decided that we wanted one entrance, one door going in, and then the doctors, the healthcare workers would come out the other way. So in the going inside, we would then create a dunning area. And then we would go through, and through the the exit that we are going to have, we would then have a doffing area. And then we also decided that close to the entrance, we would have an electronic viewing station. So sister's office, which was near to the entrance, was kind of commandeered, and we changed it. We changed all of that format, and we managed to house in that area sister's office, an electronic station, an electronic viewing station, as well as a dunning area. And so Ward 7 was taken care of as our COVID patient. But then afterwards, we had Ward 8 coming on stream. And so Ward 8 now was designated to be persons suspected of having COVID, but not yet confirmed. So our patients suspected were held on Ward 8, and when they were confirmed, they were moved to Ward 7. So now you're knowing that there may have been some mishaps along the way there. We haven't really heard of any, but it could be, you know, we imagined, and we have imagined and wondered whether there might have been. But those who were suspected were put in Ward 8. As time went by, we realized we would need more wards, more COVID wards. So we co-opted some non-COVID wards as we went along, and we converted them to COVID wards. And what happened with that, of course, was that we were now looking after far more COVID patients than non-COVID patients. And of course, during that time, persons were not very eager to go to the hospital because they knew that COVID patients were being looked after. So I guess from that, the numbers dropped. We did find a reversal though. After one of the surgeries, we started to find that we had more non-COVID patients than COVID patients. So we had to be very nimble. We had to be able to convert back a ward from reconverting it to, you know, we had to reconvert it to what it was before, depending on the numbers. Over the last period, just before this last period here, we were given a mandate that we needed to now be opening up to more non-COVID patients because we had gone way over to one side, looking at our COVID, accepting and treating and managing our COVID cases. So it was a challenge. It was not easy with that kind of back and forth thing. We went to tents So like in the A&E area, for example, which was right adjacent to the airborne isolation room, we realized that, well, that little 2-bed unit was not going to hold us. So we had then gone ahead to look at Ward 7, and then eventually Ward 8, and then eventually Ward 3. And then at the back of Ward 7, we had a medical intensive care unit that was also now commandeered for our more ill patients just before going into the ICU-A, which was now that one was our surgical ICU. So with COVID, it became our COVID ICU, and ICU-B became our other ICU for other situations. So we had to be nimble, we had to be flexible. And I would really want to commend the heads of these sections, Dr. Metalor in ICU, who was very nimble and who could foresee a challenge long before it happened and make the changes. Professor Boyne and Dr. Tamara Thompson in medicine, who also led the charge, Dr. Pate Robinson as well. And then there is Dr. Sharon East-Miles in OSHA, who was there with the staff, holding their hands and trying to help them to get through this time. Dr. Simone French and Romaine Edwards in A&E, again, playing their role. So A&E had it really bad. I'm not sure what the experience is elsewhere, but I was really sorry for them. The patients descended on them. They had a lot of positives. The space was small. Eventually, they had to again look at their A&E area, and they were able to come up with an area that they got 8 beds out of, 7 to 8 beds in that A&E area, 7 to 8 isolation areas. So now they had a COVID area in A&E as well. That became overrun very quickly, as you would imagine, during the surge. So the next move was to develop what I call a tent city. So outside you had 5 to 6 tents, and each tent could hold 4 to 6 persons. It was extremely hot because we did not have air conditioning in them initially. Later on, I think there were 1 or 2 that had, but generally speaking, no AC, fans. And you know, fans sometimes blow hot air. So it was very uncomfortable, but there were times when that is what we did. We had the tents. I must fast forward to say that in the latter part of dealing with this outbreak, the private sector, again, the RJR group of companies, I believe, stepped forward and they offered us a field hospital. So right outside A&E, a field hospital was erected, and these are the prefab buildings that you can put up and put different units together. It's really quite functional, and it has a capacity of 40 patients. Unfortunately, it came towards the end of that period. Let's hope we don't go back there, but we are using it, and we certainly will make use of it no matter what the situation is. But that was a relief because we really were feeling as if we didn't know what else to do. So that came towards the end. It's in very good condition, has isolation areas. And we initially, I think we're still saying that that's the field hospital for COVID patients. But in between, if we're in a lull and we have an overrun in other cases, there's nothing to say that we couldn't use it in that. So we would try to cohort high-risk patients together, and then we would try to get back the test as soon as possible. In this area, the microbiology lab played a valiant role in trying to make sure that results were brought back as quickly as possible. Our turnaround time was 24 hours. It was not that initially. The learning curve had to be accommodated, but with time, 24 hours. And there are times now when we can do it in less than 24 hours. We don't noise that abroad because it does put a strain on the staff and also on the resources, because we try to get the plates that we have, that we use for the test full. So we make a full load, and that would be probably about 96. But sometimes there's an emergency, and depending on the nature of the emergency, we might just test what we have now, which means that we're going to be testing 48 using a plate that has wells for 96 samples. So we are wasting the rest of that. But you know that there are times when you have to use common sense, and that makes it necessary for you to do that. We try not to do it too often, and therefore we keep this a secret. Though I'm saying it here, no, it's not a secret anymore, but we keep it a secret that we can actually give you a quicker turnaround time. In addition, antigen tests have come on board. And so there are some areas where they rely on antigen tests, but we have still held the PCR as our standard. And therefore, for doing surgery, and other areas, it is still the PCR that we regard as the standard, and we would not accept the antigen test instead.
Dr. Nicholson?
Yes,
10
yes.
minutes, please.
Sorry?
10 minutes.
Okay, all right, so I'm going to rush now
Thank
then.
you.
All right, thank you. What does that look like? Okay. All right, so the medical wards, we talked about the viewing. The electronic surveillance became a game changer. Now we could view all over. Initially, I talked about viewing into the isolation room. Now you could view all the COVID areas. So we had ICU that could view all the COVID areas. We had viewing areas outside of the hospital, outside of the various wards. And so instead of going in, you had your camera and you could actually get the attention of persons in there on using cell phone or using the ward phone. So these are your different isolation areas where you could view different areas of the ward, and this was well used and continues to be well used. Our usual infection control measures with your hand hygiene. This is the field hospital I mentioned, an outstanding example of private sector partnership. This is I won't show you the drawings. So I think we could fairly say that while we understood the challenges, we did not recognize the magnitude of what was coming. For the hospital, we regulated access. So we closed down the hospital generally. It still remains like that now. You cannot enter everywhere. Some access points were closed off, and the points that were left open are manned. So we have our security guards there. Your temperature is checked. You must have on a mask. You must show your ID, and otherwise you will not get entrance to the hospital. And everybody, staff or visitor, must go through a checkpoint. And I have to say here that this checkpoint detected 2 of my staff members as being positive. And so they were taken out of circulation. They were detected as having a temperature. They were not aware of this. They did not even feel ill, but the temperature was detected as being elevated. And so they were sent through the protocol to be tested, and 2 persons came down positive using PCR. So they were able to be pulled out of circulation very quickly. And those are 2 persons who in my department in the lab are very, very involved and therefore could have been spreaders. So there is some merit to it, I think. We eventually had testing booths where people were tested before going into A&E, deciding where they should be shunted. And in the clinics, seating was allowed. We started to put we had the clinics after a while. We suspended them for a while, but then we had them, and they were arranged, the chairs were arranged with spacing in between them, with what chairs saying do not sit here, so that we would maintain the required spacing that is recommended to interrupt the spread of this infection. And of course, there was somebody to regularly wipe the seats, and I've been in the clinics and I've seen them come around to wipe the seats. So I know that it's being done so that you have a flow of patients. They're coming into clean chairs. The ICU, I talked about the ICU A, and just to say that it was refurbished and some before COVID, so that came in handy, and they were able to do other work since COVID. So now it has 10 cubicles, 2 airborne infection isolation rooms, negative pressure rooms with anti-room and separate air handling units. 6 cubicles have negative pressure, the facility to have negative pressure, but they don't have any anti-rooms. So that's a limitation, but at least they're there. And 2 cubicles have positive pressure. And the general area is a protective environment with airflow of 16 changes per hour, 16 air changes per hour. And of course, remote camera monitoring systems were activated, and they had the monitoring system right there. And as I said before, the ICU is the only place where they can actually view the entire COVID areas in the hospital. Staff care, we would make sure that we are paying attention to our staff. We would encourage them to get tested if there was anything, so we could pluck out positive persons as quickly as possible. As an area where we were getting samples coming in, our infection rates were very low, and we were very glad for that. They've gone up a bit now, but we suspect that most of the transmission is outside of the lab and not in the lab. So, right, just to stress again, the fact of encouraging staff members to become vaccinated and to make sure that they get breaks and they're able to rest in between. This is what our positive healthcare workers look like from April 2020 to February 22. And you can almost match these with the outbreak periods. And so we're pretty sure that the strain that you isolate here would be what was typical of the period here. And of course, nobody has to ask, this one is when Omicron was identified. Right, so this is my microbe. In 2020, we had only 2.8% positive. In 2021, 11%, and in 2022, 18% so far. We have to look at that just to make sure that we're on top of it, but I think we understand where that came from. And this is now looking at our vaccination rates by staff. So if you look at admin and clerical, 60%, 100% of the physiotherapists. I must say that the physiotherapists were hard hit. I don't want to say most of them were infected, but a significant percentage, but still they were vaccinated. And I think the head insisted that they get their vaccines because there were so many of them that came down positive from very early. 87% of pharmacists, 78% of persons who work in the linen room. Transport people are not taking us on yet. Only 5% of them vaccinated. Psychiatric aides, and they've had outbreaks in that unit, but only 12% of them are immunized. So we continue with the fight because we realize that there are some barriers that we need to break down when it comes down to that. And in terms of our laboratory testing, we've had backlogs, and that created a big problem. Sometimes it's lack of reagent. Many times it was lack of reagent, and persons didn't understand that you couldn't just go to the shop and buy it. You had to wait for the supplier. This is when it was freed up now. Supplier had to be able to bring it in, delays in bringing it in, etc. But whenever that happened, it was a big problem. You had a backlog and you had increased spread, of course. So this is looking at our total tested, 112,913 in the microbiology department, and out of those, 10,000 were positive. And for February 2022, we had 3% positive and 97% negative. And this is just to look, it's a very busy slide. Sorry, but I couldn't come up with a better thing in the short time that I had. But this is just looking at the variants because we actually got some sequencing results. Most of you know that we used to rely on WHO, and we still work with them for the sequencing. So we work with them as well, but we now also have a sequencer. These results are from WHO. And the sequencer that we have now, we have started to do our sequencing and also to compare the results at times. So you see here that we had alpha first, followed by beta. Beta continued for a while into March, then delta, and then delta continued into November, and still have a little bit persisting. We also had low-level mu and alpha co-circulating with the delta. And then after that, now we had the Omicron, and Omicron went right up like this, but short duration came back down in no time. We also noticed that you had more Clostridium difficile coming in over the period. So we just wanted to make sure. We looked at 2019, and we saw that you had 36 cases of Clostridium difficile toxin samples coming in. Only 14 were, Clostridium difficile antigen, and 14% were toxin positive. Same here, 32% antigen positive, 19% toxin positive out of that. But we know that the toxin detection is not always 100%. So we decided to get the antigen test and to kind of use that as a marker as well. But in 2021, see the marked increase, 103 were Clostridium antigen positive and 69 were Clostridium toxin positive. We're assuming that perhaps with the increased use of antibiotics, persons coming in and you're giving them presumptive antibiotics if you think that they're COVID until proven otherwise, or until you think you can withdraw that. So with the increased use of antibiotics, that may have something to do with this. We're just finding this out. So we will now have to spend some time trying to define it. And our mortality rate, from March 10, 2020 to December 31, the mortality rate at UHWI was 17%. And this was a very detailed review, so we can put this one in the bank as 17%. We have looked at others, but we may not have considered all the factors. So this is just looking at the numbers, the number of deaths versus the number of admissions COVID admissions and just looking at what they look like. And this is from January 2021 to February 2022. Now, dare I say, after COVID, and this is the last one, second to last slide, if an announcement was made to thunderous applause when the Prime Minister gave his announcement that effective March 18, the orders under the Disaster Risk Management Act would be withdrawn. And this basically shows you all of the different orders that were now withdrawn. I can't go through all of them, but basically, no curfew. It was recommended that you use your discretion while staying out late for your own safety. For masks, masks are required in enclosed spaces, and while mask wearing is not mandated, it is highly recommended, especially in establishments that serve food and drinks. Entertainment, prohibition, and events will be lifted. And all of these were met with thunderous applause. We had our task force meeting this morning, and again, we were reminding each other that COVID is not gone very far, we don't think, so we should not let our guard down, but there are areas in which we can relax some of what we're doing while we allow persons to kind of catch their breath a little, but we must have certain things in place so that should COVID return, or as we get other cases, we're not caught flat-footed. And that was the consensus. So again, our task force meeting, which was normally once a day, had been cut down to once a week in recent months. And we will probably space them out even more, but the governance team will continue to meet, and we will have key persons being alert, looking for any sign of a surge so that we're not caught flat-footed, but the system, so the engine must be oiled and running so that when necessary, we can trip into action. Thank you very much. And I'm so sorry for the late start, but thanks again for this opportunity to share our experience with you.
Thank you very much, Dr. Nicholson, for your presentation. I think everybody can appreciate the force and the successful experience that we have here in Jamaica at the University Hospital. So, colleagues, we are open now for questions. We can have up to 3 questions. Please put your questions on the chat. Dr. Nicholson, while we're looking for the questions in the chat, I have one question to you. Based on your experience, do you think that all the gains that you show to us today, we will be able to keep them, like the IPC team and program, we were able to keep them, it will be sustainable for the future? Or how do you, and in case that, what are the things that can jeopardize these gains?
Right, thank you for that question, Dr. Valesco. I think that many of the gains can be maintained, but we have to be deliberate. If we are not deliberate, we're going to lose them in a flash. So we need persons who are committed, who understand, who see how important they were, and who will therefore be committed. In terms of infection control, the training across the island must continue, but I think that the resistance to some of this now should be reduced, Dr. Valesca, because people would now have seen the importance, whereas before they should have known, but they might have seen it in a vacuum. I don't think anybody now would underestimate the role that infection prevention and control plays. So I think we need to piggyback on this, and as much as possible, put pressure on the powers that be to ensure that what needs to be done to keep it center focus is maintained.
Great, thank you very much. Yeah, I think you mentioned something that is important. So we have to do it deliberate, right? Keep talking and keep showing how important we were during the pandemic to contain the pandemic. So yes. Dr. Nicholson, we have 2 questions on the questions and answers. So the first one is about the mandatory use of masks in open space. So I think you mentioned briefly that the the restrictions were released a few days ago.
Yes.
So if you can very briefly answer that, and then we have the second one.
Right. So the truth is that one of the things that what we realized, certainly at UHWI, that we were all learning. We yet had to learn the secrets of this virus. And so we were not taking any chances. And so we thought in order to maintain a discipline as well, Dr. Valeska, if we kept it on all the time, persons would get into the habit. And I don't know if you've noticed, but what I've noticed is that with time, persons were actually quite comfortable wearing masks in all different settings. I don't know if you saw that, but I saw that and I thought to myself, boy, you know, they've just been trained to wear the mask and they've been wearing it. Yes, now people breathe a collective sigh to say we can take it off in open places. And I'm supporting that as well, because in an open space, you're going to have dilution of whatever it is that you have. It's in the closed space when you have a source, continuous sources amongst yourselves. You're not sure who might have the organism and who might be circulating it. So I think that using it, keeping the mask in the closed setting is definitely important. It's mandatory to be using it in that setting. But in an open setting, I think you could relax it. The benefit of saying that you're training people to maintain the mask and to be comfortable having it, I think we have achieved that. I am not sure that I would want to keep it going if there's a chance that we can relax it. And I do believe this is one of the opportunities to relax it, as long as you keep reminding people that at any point now you're going to be reeling them in. Not sure if I'm answering what you're asking, Dr. Valeska, but those are my thoughts.
No, I think so. I think the answer is yes. Not right now. In open space, mask is not mandatory anymore, right? In Jamaica.
Correct.
Yeah. So then we have a question from Bermuda. That is, what is your school situations like now versus during the peak and various waves that you have? As you now live with COVID, or I will complement the question, or we are still in war mode. So how is your school? So can you see the question, Dr. Nicholson?
No, I'm hearing, I'm not seeing the question, but I'm hearing.
So if you go to the question and answer button, so if you stop to share.
Oh, yes.
Okay.
Yes. I'm seeing it now, thanks. Okay, so I'm not sure what is happening right now. I honestly don't know what is happening since the 18th of March. I do know that in our setting, you know, in our medical school and so on, the students are still being asked to wear masks. And because of the healthcare setting, we are still going to be wearing masks in our setting. We are going to be meeting in another day or two to decide whether we should relax it. My personal opinion is that we should keep the mask in the healthcare setting. I really don't know what's happening in the schools since the 18th of March. That I will have to check on.
Okay, thank you very much. So I think we have to finish the session, unfortunately. So I'd like to thank all the participants who keep their attention and the questions. And I also, of course, would like to thank you very much, Dr. Nicholson, to share with us the experience that you have, your knowledge, right, the challenge that you face, how you overcome it. Have many comments in the chat commending you for your presentation and your work. So thank you very much for the work and also for the presentation. So we are finishing. I just would like to remind you that we will have 2 events next month in April. So April 18, 19, and 20, we will have a workshop about reprocessing of medical devices, including N95. And in April 28, we will have a seminar about the impact of AMR during COVID. So I would like to thank you again. Thank you, the team. Thank you, the translators for this session today, and see you next month. Thank you very much.